The death toll has now reached over 1,000 in Guinea, Liberia, Sierra Leone, and Nigeria. The disease, masked in dark superstition and mysticism, continues to ravage West Africa in alarming rates and has triggered an international public health emergency. We know experimental drugs exist, but who's getting it? And how are they deciding? That's today on The Global African. I'm Bill Fletcher. Thanks for joining us. Ebola hemorrhagic fever first appeared in the 1970s in two simultaneous outbreaks in the Sudan and Congo. The name originated from the Ebola River in a village in what is now known as the Democratic Republic of the Congo. Since then, numerous small outbreaks of the disease have occurred, mainly in those countries, but its recent reoccurrence has been marked as the worst in history. Patient 0 of the current outbreak is believed to have been a 2-year-old toddler from a village in Guinea. Ebola, which currently claims up to 90% of its infected, calls its home in areas where health services aren't optimal and cultural beliefs breed distrust for aid workers, literally making West Africa the perfect breeding ground for a disease that could be prevented by basic health care. And while myths and urban legends have been born out of the slow apparent recovery of the 2 Americans infected with the Ebola virus, CDC Director Tom Frieden has made it clear that we're months and perhaps years away from the mass distribution of the experimental vaccine ZMapp. And more of an immediate problem is a lack of basic medical care necessary in those countries for the vaccine to even be administered. Although mass distribution is a far-flung hope for the future, angst is arising over who's being chosen to test the drug. Namely, only 2 Americans and 1 Spaniard who was recently infected. Is pharmaceutical racism at play even when it comes to trying to stymie the worst Ebola outbreak in history? Today on The Global African, we'll talk about what Ebola means for public health at large, separate fact from fiction, rhetoric from truth, and lift the veil on a disease so shrouded in stereotype and mystery. Helping us to better understand the extent, scope of the Ebola crisis is Dr. Taha Taha. Dr. Taha is a professor of epidemiology and population, family, and reproductive health. He's the co-director of the infectious disease area of concentration in the Department of Epidemiology, Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. Dr. Taha is a physician with extensive training and experience in infectious diseases, community medicine, public health, and demography. Dr. Taha, welcome to the program.
Thank you very much.
Thank you.
Thank you for having me.
Could you give us some background on the epidemiology of Ebola?
Ebola, it was known as Ebola hemorrhagic fever until recently, and now it is called Ebola virus disease. It is a severe disease, infectious disease, and often it is fatal. As we see from the reports today, of those who are infected, a proportion of over 80% would die. So it is an infectious disease. It is a severe disease. However, we know very well what Ebola is today. Since 1976, we have been through several outbreaks. And what is happening in West Africa today, we believe, is not different from what has happened in the past. It could well be more severe as far as the numbers are concerned, but we have enough experience about Ebola virus disease.
Tell us, how does it spread? I heard President Obama assure the public that it's not airborne. How precisely is it spread?
Yes, indeed, the major mode of transmission is not airborne. It is not like several infectious diseases we have seen recently, emerging infections that are spread airborne. However, Ebola is transmitted through direct contact, be that the patient or the secretions from the patient, any bodily fluid, be that urine, the vomitus, the fluids that come out from the body, any of these could be infectious. And the virus can remain infectious for a couple of days outside the body, as far as there is fluid and there is material. But direct contact or indirect contact is the main mode of transmission. It is different, for example, from HIV. It is different from some other infectious diseases we know that are airborne. So as far as being infectious, we know the mode of transmission, and it requires intimate contact with an individual who is infected or dealing with infectious material from that individual. It is not transmitted through the air.
Can this be stopped, this outbreak?
Yes. I think thinking of preventing or controlling this outbreak, we need to probably, for better of understanding, consider two settings. One is the community, and one is the healthcare system. The healthcare system, especially the hospital, acts as an amplifier. Individuals who are sick go to the hospital. Usually during the early days of the outbreak, it is not well known. It resembles so many diseases like malaria and so many typhoid fever, respiratory diseases that are quite prevalent in these remote areas where these outbreaks occur. So what happens in the hospital is very important, and a degree of vigilance and management of throughout the year or throughout all times, the hospital should be alert and doing the appropriate and reasonable management for these contacts. However, these healthcare systems, the infrastructure is very poor. The personnel is not always stable. So there are breaks in this system. Therefore, when these outbreaks occur, the healthcare system is not able to handle. And therefore, it becomes another source that actually facilitates transmission. So this is the healthcare system. So management of these cases in the hospital is very important. It's very critical.
What did you make of the stories that we were hearing about entire villages that would not allow medical personnel to enter?
So this is the part of the community. So we said something about the healthcare system. The community is very important. Usually these outbreaks occur in very remote areas where the communities are not accessible. Being alert or knowledgeable about these outbreaks is not all the time present. There is stigma, there is lack of information, rumors, and so many other negative things. When these diseases occur, these outbreaks occur, people become more not allowing the health personnel or others from outside to get to the village and know what is happening. So what happens in the community is probably natural, but it requires community participation, education, and some level of trust.
And I understand that there are burial processes or rituals that are followed in many West African communities that actually help to perpetuate the spread of this disease.
Yes, indeed. And I personally can tell you, I mean, I have greeted or I have managed one or two cases of Ebola. I have seen them. So just casual contact is not the problem. But these burial processes and how they prepare the individuals who are infected, and these activities, of course, it is not specific for Ebola. This is what they do all the time, that they take care of the dead, whether someone is not there or not. So there are certain rituals that these communities, and based on, of course, religious and traditional and so many other things, this is what they do all the time. So not, for example, preparing a case of or an individual who has died of Ebola in the same way might not be the norm. But certainly individuals who die are taken to the village and prepared, and then the burial process. So in this process, And usually this is done by, say, for example, some elderly or individuals who have no knowledge of what they are dealing with. And this is certainly very infectious. So the washing the individual or preparing the individual for burial and then the ceremonies that goes with that is quite substantial. And there are several steps during this process that the individuals who are handling this the disease might become exposed.
In the recent past, within the last week or so of the outbreak, in the United States, there have been some very strange political commentators, particularly on the right, the right wing, that in responding to this have been sowing seeds of what feel like panic, extreme measures, not letting victims of Ebola return to the United States and other such things. It would be useful for you to explain what's the relative danger in the United States, and what do you say when a commentator says, no, shut the border, you can't allow any Ebola victim in the United States?
It is probably fair to say that the likelihood of Ebola getting established in the US is almost nil. It is very minimal. There is a very good healthcare system. The amount of vigilance, the surveillance, and management of these cases, should it ever appear in the US, will not be difficult at all. What is more problematic are in remote areas, in the villages of Africa. That is where these things originate. And then it moves to the urban setting like what is happening in West Africa. But it is not a threat to the US. It is not a spread through handshaking, or that people, of course, need to be careful. But it is not casual spread. It is not airborne. So there are features that are different from other infectious diseases. So thinking that Ebola can spread in the US the likelihood is very minimal. However, precautions should be taken, and this is not any different from other disease. So it is an emerging infection. It happens from time to time. However, managing 2 individuals or 3 individuals in the US, or it doesn't have any chance for the disease to spread.
Dr. Taha, thank you very much for this illuminating discussion and helping to dispel the myths and fears that are being propagated, but also grounding this in the seriousness of the situation facing West Africa. Thank you very much.
Thanks very much for the opportunity.
Our pleasure. And thank you for joining us on this segment of The Global African. We'll be back in a moment. As we explore the Ebola crisis, we're joined by Ms. Amira Woods. Amira Woods is the Director of Social Impact Programs for ThoughtWorks, a technology firm committed to social and economic justice. Amira is a steadfast advocate for the African world, labor rights, environmental justice, land rights, food sovereignty, and peace. Prior to ThoughtWorks, Amira worked with the Institute for Policy Studies, a Washington, D.C. progressive think tank, and she was there for over 11 years. Amira, thanks for joining the program.
Bill, it is always a joy to be on Telesur, to reach such a broad audience, and it's even more special to be on with you, a longtime comrade. Thank you for having me.
It's our honor. Amira, I want to go straight to the chase on this. This Ebola crisis, this is personal for you. I mean, this is about Liberia.
You know, it doesn't hit closer to home. It is the epicenter of this crisis is the Mono River countries, as we call them. It's Liberia, Guinea, Sierra Leone, the region bordering those 3 countries in West Africa. But yes, it hits very close to home. About 2 weeks ago, we got a call that Dr. Brisbane, who's a longtime Liberian health professional, was a longtime friend of my father's, that he died as the lead health provider in the Ebola crisis. To have him be stricken and then to lose him was a blow for a country that has, health professionals, let's just say that are in small numbers, are not in the numbers needed to meet the needs of the country and the region. So what you see in a very real and personal way, for many of us, Liberia is a country of about 3 to 4 million people, many of whom are related and connected in all kinds of complicated ways, and so the deaths now in the region, well over 1,000 people have died as a result of this Ebola virus, and it hits very, very close to home, Bill, without a doubt.
As a Liberian looking at this situation, how do you explain to our listeners and viewers the way that this crisis unfolded? Why did it unfold this way in Liberia?
Well, Bill, I think it's important, to pull back the lens and to understand really the conditions that have created such a catastrophe on the ground today. And, we're here in Washington, D.C., and we often talk about issues like the Washington Consensus and neoliberalism and all the flaws of a capitalist economy. And really what you see happening before us today is a crisis in a healthcare system completely dismantled by structural adjustment programs, by decisions made, whether it's the World Bank, the International Monetary Fund, these international financial institutions that in their economic models decided that the right thing to do to bring economic stability to regions around the world would be to cut back in public sector spending, cut back in the essential services, whether it's education or healthcare. It was those essential services that were really the first to go. And so what you see is a de-emphasis of basic infrastructure that would build healthy societies. And it's so clear today that when you take away funding for public sector services like health, affordable healthcare, that public sector infrastructure that is so desperately needed now, was actually dismantled over the last few decades by policies set here in Washington, D.C. And so I think we've got to go to the root of the crisis. You also see, education, basic information flow, the systems of channeling information to people just not in place. I'm now working at a technology firm, that is committed to using innovation to build a better world. And what you see are even the basics of the infrastructure that would be able to get information out to people in a steadfast manner in the midst of this crisis. That infrastructure is not in place. And so, while there's been this push to privatize essential services, we talk about it in the policy circles, but it really hits home when there's a crisis like this that's devastating a region that is woefully ill-prepared to kind of meet the demands of this catastrophe.
Amira Woods from ThoughtWorks, thank you very much for joining us on this segment of The Global African.
Well, it's an honor to be with you. Thank you for all you're doing to advance the struggle for human dignity around the world. Stay strong.
Thank you. And thank you for watching this segment of The Global African. This is your host, Bill Fletcher. We'll be back in a moment. Joining us to discuss the public policy and public health aspects of the Ebola crisis is Dr. Lawrence Brown. Dr. Lawrence Brown is an assistant professor in the Department of Health Policy and Management, Environmental Health Sciences at Morgan State University. He specializes in understanding how health disparities, health systems, and health policy jointly work to impact the health outcomes of populations. Thank you for joining us.
Thank you for having me.
The discussion about Ebola has largely focused on the medical side of this. But it seems to me that the Ebola crisis is a medical, political, and public health crisis. Would you agree with that?
Absolutely. I mean, health is a very holistic, it's a function of multiple factors and a variety of issues that come into play. Our health, generally speaking, is caused by the environment, genetics, even our behavior, and the healthcare system. And so what we're talking about with Ebola is how the confluence of all these factors come into play. You have everything from the environment, how this disease emerges from nature and interacts with animals and humans. You also have the healthcare system, which is woefully inadequate to meet the present challenge. But you also have the economic system that plays a role. West Africa and Africa in general is developing at a tremendous rate. Several of the fastest growing economies are in Africa, but the healthcare system hasn't been given the type of attention that it needs in order to meet the demand that this disease presents.
Is this a situation where, analogous to the HIV/AIDS crisis, where there needs to be a multilateral, multinational response like the United Nations?
Well, certainly there should be a multilateral, multinational response, but I think it's interesting that you brought up HIV, because HIV is a disease that Africans have been largely stigmatized.
That's right.
As it relates to the nature of the disease, and that's also true with African Americans here in the United States. So with Ebola, I think a lot of the same thing is happening. You have the racialization of a disease with Ebola. I don't know if you recall, a few weeks ago in the United States, there was a Oakland reporter said that there was a disease called hood disease impacting urban, particularly black youth. So diseases can actually become racialized in a way that stigmatizes and minimizes and reduces and slows down the response that people can have to a disease.
When you say disease becomes racialized.
Right, so medicine actually is a function of culture. And so if you have a culture that is demonizing, stigmatizing folks in the world, then what will happen is the disease that's in question will actually be, there will be a different type of response than there would be to those who are not stigmatized, who are not marginalized. And so I think we have to be really careful in the way that we look at this disease, that we make sure that we're not stigmatizing and say, ooh, Ebola, oh, those Africans who are, as we have these racialized ways of understanding Africans as being poor, living in the jungle, all of these ways that I think we stigmatize Africans. And we have to make sure that we understand 1,000 people have already died from this disease, 2,000 are affected, and there's a chance that it can grow any day. But our perceptions of the African people can actually play a large role in how this disease will be contained.
What would you say to African Americans in the United States about the Ebola outbreak and how we should respond?
So marginalization itself, racialization, the demonization of populations, if we know here that it has a negative impact, then we need to be speaking up and cautioning the folks that are going over, cautioning the people that are rushing to help, as they say. We need to make sure that they're aware of the cultural implications, the cultural issues that are at play. Because if you don't control and correct for marginalization and demonization, then you're going to have a situation where people are going to be running around with myths in their mind. They're going to be having misconceptions, misconstruing. They may go over and treat the people with disrespect and expect their cooperation, or they may come over thinking that I have the knowledge, you should do what I say, but did you work to develop trust first? And so those are the sort of cultural things and implications that we have to make sure that these doctors, nurses, public health professionals, epidemiologists, they understand that they can't bring their privilege into their operation, into their work. They have to make sure that they're culturally relevant, culturally congruent with the population that's in Africa. Because we know here that if you're not culturally congruent, the disease or any disease won't be effectively contained.
Dr. Brown, thank you very much for your time.
Thank you for having me.
And thank you for joining us for this episode of The Global African. I'm your host, Bill Fletcher. Look forward to seeing you next time. Thanks for joining us.